Hi guys, welcome back to my channel. So lately I have been getting a lot of comments to create a video on vitamins. So here I am today with all what you need to know about vitamins in a tabular and MCQ based discussion. So let's begin our discussion on vitamins. Vitamins are divided into two subtypes: fat soluble vitamins and water soluble vitamins. Vitamin A, D, E, K come under fat soluble vitamins, whereas vitamin B and C come under water soluble vitamins. Fat soluble vitamins absorption depends on intestine and pancreas. Toxicity is more common since these accumulate in the fat. They are not excreted in urine as they are hydrophobic. Malabsorption syndrome such as celiac sprue, cystic fibrosis or mineral oil intake can cause fat-soluble vitamin deficiencies. Whereas water-soluble vitamins are excreted in urine and hence cannot accumulate to toxic levels in the body. All B complex vitamins wash out easily from the body except B12 and folate B9. Sulfur-containing vitamins are thiamine B1 and biotin B7. Folic acid and vitamin B12 are called hematopoietic vitamins since they are required for normal maturation of RBCs because of their role in DNA synthesis. Vitamin B1, thiamine, B2, riboflavin and B3, niacin, B5, pantothenic acid, B6, pyridoxine, B7, biotin, B9, folic acid, B12, cobalamin and C is known as ascorbic acid. Now let's learn more about folic acid and biotin. The sources of folic acid are green leafy vegetables, dried beans and peas, lentils, liver. Normal blood levels of folic acid are 2 to 3 nanogram per ml, RDA 400 mcg, whereas the sources of biotin are egg yolk, liver, cereals yeast, RDA 30 mcg. Function of folic acid is active form THF tetrahydrofolate, major circulating form methyl THF, major point of entry for I carbon transfer by substituted folate is methylene THF. Coenzymes for 1-carbon transfers involved in methylation reactions required for synthesis of bases in DNA and RNA. Supplementary folic acid in early pregnancy reduces neural tube defects. Recommended dose is 400 mcg per day. The functions of biotin include cofactor for carboxylation, pyruvate oxaloacetate, acetyl coenzyme A, melanin coenzyme A, propionyl coenzyme A and methylmalonic coenzyme A. Deficiency of folic acid results in macrocystic megaloblastic anemia due to defective DNA synthesis in RBCs. Figlo test: histidine normally metabolized to forminoglutamic acid from which formimo group is removed by THF. Hence in folic acid deficiency, Figlo is excreted in urine. AICR excretion: aminoamidazole carboxymide ribosyl 5-phosphate accumulates and is excreted in urine. The deficiency of biotin caused by antibiotic use, excessive ingestion of egg whites. Deficiency causes dermatitis, alopecia, parathesia and enteritis. Deficiency of biotin plus carboxylase leads to multiple carboxylase deficiency. Meanwhile, let's practice some MCQs. A woman develops anemia in the 6th month of her first pregnancy. Blood workup reveals hypersegmented neutrophils with increased mean cell volume, morphological alterations in other cell types and elevated serum level of homocysteine. Which of the following is the most likely cause of anemia in this woman? Option A, folate deficiency. Option B, iron deficiency. Option C, glucose 6-phosphate dehydrogenase deficiency and option D, lead poisoning. So which option do you think is the correct one? Well, yes, option A, folate deficiency is the correct answer. Let's talk about folate deficiency. Symptoms: hypersegmented neutrophils, increased mean cell volume, morphological changes in other cells. Mechanism: folate needed for DNA synthesis. Deficiency leads to delayed cell division, forming abnormally large cells. Megaloblastic anemia. Homocysteine: elevated due to impaired conversion to methionine. Affected cells, rapidly dividing cells like bone marrow and intestinal mucosa. Diagnostic markers, elevated homocysteine, normal methyl malonic acid. Prevention, folate supplements before conception, reduce neural tube defects. Our next question is, which of the following is involved in the conversion of these amino acids given in the image? Option A, ammonia. Option B, tetrahydrofolate. Option C, vitamin B12. Or option D, vitamin B1. So which option is correct? Yes, option B, tetrahydrofolate is the correct option. Let's move ahead and discuss the key features of tetrahydrofolate. Glycine is the simplest amino acid. It is non-essential and is glucogenic. Glycine is formed from serine. The beta carbon of the serine is channeled into the 1 carbon pool carried by THFA, tetrahydrofolic acid. The alpha carbon of serine becomes the alpha carbon of glycine. Serine to glycine conversion is reversible. Serine can be directly converted into glycine by serine hydroxymethyl transferase in a reaction that yields N5 and 10 methyl tetrahydrofolate from THF. A methyl group is transferred from serine to THF in this reaction. Our next question in line is, a 25-year-old young wrestler presents with complaints of weakness and fatigue from the last month. On examination, the patient reveals that he has been consuming half a dozen of raw eggs every day. Labs reveal hypoglycemia after the initial investigation, and the patient is prescribed vitamin tablets. Based on the given condition, which enzyme deficiency is causing hypoglycemia in this patient? Option A, phosphophenol pyruvate carboxykinase. Option B, pyruvate carboxylase. Option C, glycogen phosphorylase. Or option D, glucose 6 phosphatase. So which option do you consider the right one? Well, yes, option B, pyruvate carboxylase is the correct answer. Now let's discuss the key features of pyruvate carboxylase. Excess raw egg consumption leads to biotin deficiency due to avidin binding. Avidin tightly binds to biotin, vitamin B7, and is excreted along with biotin, leading to biotin deficiency. Biotin is necessary for carboxylases like pyruvate carboxylase, converts pyruvate to oxaloacetate. Pyruvate carboxylase is the first enzyme of gluconeogenesis. Decreased activity of this enzyme will cause low gluconeogenesis in fasting conditions, resulting in hypoglycemia. Avidin denatures when cooked, reducing biotin binding, making cooked egg whites safe. Now let's move ahead and talk about water-soluble vitamins. Let's begin with discussing thiamine B1. It is obtained from cereal grains, beans or pork. Active form thiamine pyrophosphate. TPP is a cofactor for oxidative decarboxylation reactions. TPP is also a cofactor for transketolase in HMP shunt. Hence, B1 deficiency can be assessed by checking RBC transketolase levels. Thiamine deficiency seen in alcoholism, malnutrition. Dry beriberi, polyneuritis, symmetrical muscle wasting. Wet beriberi, high output cardiac failure edema. Wernicke's encephalopathy, global confusion, ophthalmoplegia, ataxia. Lactic acidosis due to dysfunction of pyruvate dehydrogenase. Now let's move ahead and talk about riboflavin B2. It is obtained from milk, cofactor in oxidation and reduction. Enzymes containing riboflavin are called flavoproteins. The two coenzymes are FMN and FAD. Riboflavin is also called Warburg's yellow enzyme. The marker of riboflavin deficiency is glutathione reductase activity. In deficiency, angiostomatitis, chiliosis, corneal vascularization are seen. Next we have niacin B3. Sources: plants, meat, fish. Niacin can be formed in the body from tryptophan. Function: constituent of nicotinamide adenine dinucleotide phosphate used in oxidation reduction. Deficiency. Pellagra can be caused by Hartnupp's disease, malignant carcinoid syndrome. A staple condite also causes B3 deficiency. Diarrhea, photosensitive dermatitis, dementia, beefy glossitis, death. Casals collar, necklace, erythematous rash. Moving ahead, next we have pantothenic acid B5 obtained from meat, milk. Function, constituent of coenzyme A and component of fatty acid synthesis. Pantothene is the functional unit of these two coenzymes, which is formed by the combination of pantothenate with cysteine. Deficiency leads to dermatitis, alopecia, enteritis, adrenal insufficiency. Next, we have pyridoxine B6. Sources: meat, fish, potatoes, bananas. Function: active form pyridoxal phosphate. Used as a cofactor in decarboxylation, transamination, condensation. Glycogen phosphorylase, heme synthesis, synthesis of lysine from tryptophan. PLP dependent condition. Homocystinuria, oxaluria, xanthinuria, aciduria and sideroblastic anemia. Deficiency leads to peripheral neuropathy, anemia, convulsions, hyperirritability, oxalate kidney stones, deterioration of CNS leading to Parkinsonism. Next, we have cobalamin B12, found only in animal products. A small amount of B12 is synthesized in the intestine by intestinal microorganisms. Cofactor for homocysteine methyltransferase, cofactor for methylmalonyl, coenzyme isomerase. Deficiency is caused by malabsorption, lack of intrinsic factor, absence of terminal ileum. Microcytic megaloblastic pernicious anemia, subacute combined degeneration, optic neuropathy, paresthesia, glossitis. Next we have ascorbic acid, that is vitamin C, which is obtained from fresh fruits, citrus fruits, fresh vegetables. Function: antioxidant, involved in hydroxylation of proline and lysine in collagen synthesis. Facilitates iron absorption. Cofactor for dopamine B hydroxylase. Prophylactic against neuroletharism. Deficiency leads to scurvy, bruising, anemia, swollen gums, poor wound healing, corkscrew hair, unemerged coil hair. So after water-soluble vitamins, let's discuss fat-soluble vitamins. So let's begin with discussing vitamin A. It is obtained from liver, milk, butter, cheese, fish oil, orange, red-colored fruits and vegetables. Functions include: retinal combines with light-sensitive protein opsin to form rhodopsin. Deficiency: night blindness, squamous metaplasia of corneal and conjunctival epithelium, dry eyes, bited spot, dry eyes. Next we have vitamin D, formed in sun-exposed skin, increases intestinal absorption of calcium and phosphate. Deficiency leads to rickets in children, osteomalacia in adults. Next we have vitamin E, vegetable oils and seeds, almonds, nuts, spinach. Function includes antioxidant action, prevents rancidity of fats, helps the body to use vitamin K. Deficiency leads to increased fragility of erythrocytes, hemolytic anemia, neurodysfunction. Next we have vitamin K, obtained from green vegetables, dairy products, catalyzes gamma carboxylation. Vitamin K dependent clotting factor 2, 7, 9 and 10. Vitamin K's deficiency leads to neonatal hemorrhage, clotting and bleeding disorders. So the last slide before solving MCQs is vitamin deficiency diagnosis. Vitamin B1, the investigation is RBC transketolase activity. For B2, investigation is glutathione reductase activity. Niacin deficiency is investigated by RBC niacinamide concentration. For B6, we do xanthuria acid levels, and for patient preparation, we load tryptophan. The investigation for B12 is MMA level and patient preparation overnight fast. Folate deficiency, investigation include Figlu level and patient preparation histidine load. So now let's practice few MCQs of vitamins. A 35-year-old alcoholic malnutrition patient presents to the hospital with respiratory distress. He presents with no family history of cardiovascular disease. On examination, the patient had a pulse rate of 112 per minute and blood pressure of 147 by 84 mmHg, with a systolic murmur along the left sternal edge and lower limb pitting edema. A diagnosis of congestive high output cardiac failure was made. Which of the following tests will most likely support the diagnosis? Option A, erythrocyte transketolase activity. Option B, RBC glutathione reductase. Option C, RBC thymine levels. Or option D, serum thymine levels. Well, yes, option A, erythrocyte transketolase activity is the correct option. So what is erythrocyte transketolase activity? Vitamin B1 is water soluble, with its active form being thymine pyrophosphate. Acts as a cofactor for enzyme including pyruvate dehydrogenase, ketoacid dehydrogenase, alpha ketoglutarate dehydrogenase, and transketolase. Thymine deficiency, common in chronic alcoholics, lead to wet cardiac beriberi due to impaired oxidative decarboxylation reactions affecting highly aerobic tissues like the heart and brain. Assessment by erythrocyte transketolase activity, as it's involved in the HMP pathway and RBCs. So let's move forward to the next question. A 26-year-old woman has a 3-month history of recurrent upper respiratory tract infections. She has a history of celiac disease and experiences frequent bouts of diarrhea. She frequently stumbles into the nightstand when she gets up to go to the bathroom at night. Physical examination shows generalized dry skin, multiple bruises on the shins, and triangular keratin plaque on the temporal conjunctiva. Which deficiency is the most likely underlying cause of these findings? Option A, vitamin A. Option B, vitamin C. Option C, niacin. Or option D, riboflavin. So which option do you think is the correct one? Yes, option A, vitamin A is the correct option. Now let's talk about vitamin A deficiency manifestations, ocular manifestations, night blindness, conjunctival cirrhosis, bited spots, corneal cirrhosis, corneal ulcer included 1/3 of cornea, corneal ulcer involving more than 1/3 of cornea, corneal scar, xerophthalmic fundus. Next we have skin manifestations, phrenoderma, follicular hyperkeratosis, xerophthalmia, bitot spot, keratomalacia, corneal opacity. Our next question is, a 29-year-old primigravida woman with a history of inconsistent prenatal care gives birth to a newborn by spontaneous vaginal delivery at 36 weeks. Physical examination of the baby in the nursery shows a newborn male with a fleshy swelling on his sacral region, just above the gluteal cleft. His upper limbs are moving adequately, however, his lower limbs show decreased or no apparent movement. The inadequate intake of one of the vitamins during pregnancy causes this defect. It plays a pivotal part in synthesizing nucleotide and acts as a carrier of the carbon atom. Which of the following biological reactions do not utilize carriers for carbon groups in the biosynthesis of compounds? Option A, de novo purine synthesis. Option B, OMP synthesis. Option C, regeneration of methionine, or option D, synthesis of serine. Yes, option B, OMP synthesis is the correct answer. So now let's discuss this case and learn about OMP synthesis. A 29-year-old primary gravida woman with inconsistent prenatal care gives birth to a newborn with a sacral swelling and lower limb paralysis at 36 weeks. The swelling indicates a neural tube defect, likely caused by inadequate folic acid intake during pregnancy. Folic acid deficiency is common, particularly among pregnant women, and supplementation can prevent neural tube defects like spina bifida. Spina bifida leads to spinal cord and spine malformation, resulting in symptoms such as lower limb paralysis, urinary bowel inconsistency, and orthopedic issues. Folic acid is crucial for 1-carbon metabolism, transferring single carbon atoms in synthesizing amino acids, purines, and pyrimidines. However, the synthesis of orotidine 5 monophosphate (OMP) does not involve carriers of single carbon atoms. The conversion of OMP into uridine 5 monophosphate does use carriers like tetrahydrofolate. Folic acid deficiency is the most common vitamin deficiency, particularly among pregnant women and alcoholics. Our next question is, an 11-year-old boy presents with changes in the sclera of the eye and he also complains about dryness in the eyes. On examination, the eyes are dry and crusted. His skin is also crusted and scaly and he complains of itching. He also tells about his recurrent infections on and off. Which micronutrient deficiency can give rise to the following eye findings? Option A, vitamin A. Option B, vitamin D. Option C, vitamin E. Or option D, vitamin K. Which option do you think is the correct one? Yes, option A is the correct answer of this question. So now let's talk about this case and talk about vitamin A. The patient presents with typical signs and symptoms of vitamin A deficiency. The given picture shows bited spots seen in vitamin A deficiency. Bited spots, a foamy appearance in the conjunctiva due to superficial deposition of keratin. Dry skin and dry eyes are features of vitamin A deficiency. Vitamin A deficiency as graded by WHO: night blindness XN, conjunctival xerosis X1A, bited spots X1B, corneal xerosis X2, corneal ulcer covering less than 1/3 of the cornea X3A, corneal ulcer covering the least 1/3 of cornea defined as keratomalacia X3B, corneal scarring XS, xerophthalmic fundus XF. Moving ahead to the next question, a 9-year-old child complains to his mother about his problem that he cannot see properly after 5 pm. The mother calls her brother, who is a doctor, and consults him about the child's problem. He immediately says that there could be vitamin A deficiency, as there is no family history of any such problems. What would be the first sign that the vitamin is deficient? Option A, poor mental growth. Option B, conjunctival xerosis. Option C, hydrocephalus. Or option D, phrinoderma. So the correct answer is option B, conjunctival xerosis. So now let's discuss about conjunctival xerosis. The first clinical sign of vitamin A deficiency is conjunctival xerosis. Conjunctival xerosis is a dry and dull appearance of the conjunctiva. The first symptom is night blindness. Vitamin A deficiency also causes dryness in the eyes. Its deficiency also causes dryness and itching of the skin. Vitamin A deficiency can also cause follicular hyperkeratosis of the skin. The recommended dietary allowance RDA of men and women is 900 and 700 UG retinol activity equivalent RAE per day. Our next question is, a 24-year-old male patient presents to the outpatient department with complaints of bony pain, nausea and diarrhea. The patient states that he has recently started consuming an excess of vitamin supplements for good health. Physical examination reveals scaly dermatitis and hepatosplenomegaly. Which of the following is the most abundant provitamin form of the vitamin present in excess in this patient? Option A, beta carotene. Option B, alpha carotene. Option C, retinol. Or option D, retinaldehyde. So which option is correct according to you? Well, yes, option A, beta carotene is the correct option. Now let's talk about the key features of beta carotene. Patient presents with vitamin A toxicity, exhibiting symptoms like bone pain, scaly dermatitis, hepatosplenomegaly, nausea and diarrhea. Beta carotene, a plant derived provitamin A, is a key contributor to vitamin A levels. Treatment of vitamin A toxicity involves discontinuation of vitamin A supplements and avoidance of food high in vitamin A. Our next question is, a 70-year-old Southeast Asian woman who has recently immigrated is presented to a primary care physician for progressive vision loss. Upon further counseling, it was revealed that her poor vision worsens at night, causing her to frequently run into the bedroom wall. Her physical examination showed dry conjunctiva with a foamy looking spot and a small buildup of keratin debris. Based on the overall analysis of her signs and symptoms, the physician suspects that the patient is suffering from fat-soluble vitamin A deficiency. Which of the following medical condition is the most likely to suffer when there is a deficiency of a fat-soluble vitamin? Option A, iron deficiency anemia. Option B, Wernicke-Korsakoff syndrome. Option C, megaloblastic anemia. Or option D, osteomalacia. So which option is correct according to you? Well, yes, osteomalacia is the correct answer. Let's talk about osteomalacia, the symptom of night blindness with the presence of a bited spots, gray-white patches on the conjunctiva due to keratin buildup. In this patient clearly indicates a deficiency of vitamin A. It is seen in individuals with poor diet, alcoholism, fat diets, anorexia nervosa and poverty, or with fat malabsorption. Deficiency of vitamin A manifests with teratogenicity, stunted growth, night blindness, thinning hair due to dysregulation of keratinocytes, generalized dry skin, xerophthalmia, bited spot, and phrenoderma. Although the patient is deficient in vitamin A, the question itself is testing one's knowledge of fat-soluble vitamins, which include A, D, E, and K. Vitamin D deficiency reduces intestinal absorption of calcium and phosphate, leading to rickets in children and osteomalacia in adults. So the second last question for the day is, a 12-year-old boy presents to the clinic with complaints of a rash and difficulty balancing while walking. A picture of the rash is given below. He has been prescribed vitamin B3 supplementation in the past, which did not resolve his rash. His mental development is normal and he has achieved his milestones adequately. What is the most likely diagnosis? Option A, multiple carboxylase deficiency. Option B, biotinidase deficiency. Option C, L-captonuria. Or option D, Hartnupp's disease. Yes, the correct option is option D, Hartnupp's disease. Now let's discuss about Hartnupp's disease. Hartnup disease is an autosomal recessive disease caused by a defect in the transport of monocarboxylic amino acids by the intestinal mucosa and renal tubules. Most children with the disease remains asymptomatic. In symptomatic patients, there is cutaneous photosensitivity causing a pellagra-like rash on skin exposure. Some patients may exhibit intermittent ataxia and psychological disturbances, but mental development is usually normal. Treatment includes a high protein diet and nicotinic acid. So finally, here is the last question of today, which is, An individual presented with chronic diarrhea and dermatitis on the skin of the trunk and lower neck. The symptoms are considered to be consistent with vitamin deficiency. In this patient, which amino acid should be able to spare the dietary requirement for this vitamin? Option A, tryptophan. Option B, methionine. Option C, cysteine. Or option D, tyrosine. So which option do you think is the correct one? Well, yes, option A, tryptophan is the correct option. So let's end up this video with discussion of the key features of tryptophan. The signs of diarrhea, dermatitis and dementia are characteristic of pellagra, which is caused by niacin deficiency. Niacin deficiency usually presents as a lace-like rash on the trunk, non-settling diarrhea and dementia. Since niacin is synthesized from tryptophan and supplementation is necessary for its synthesis, a high-protein diet containing tryptophan can overcome the deficiency. Tryptophan forms niacin, vitamin B3, and is considered a niacin-sparing amino acid. Generally, vitamins cannot be synthesized in the body, but an atypical vitamin is a vitamin that can be synthesized in the body, for example, vitamin B3, niacin, and vitamin D. So finally, this video comes to an end. That's all for today, and thanks for watching.